And today we're going to talk about some basic kind of analysis that we conducted back in the early of the pandemic of 2020. So today we're going to talk a little bit about that analysis and looking at the HPV vaccination and the potential of cross-reaction to the coronavirus. So we were fortunate to be able to publish with Dr. Yarrow's journal, and that has been published. But briefly, today we're going to talk a little bit about the abstract in regards to our research paper. Back in 2020, essentially, for this analysis, we looked from March 17th to October 20th of 2020. And based on this kind of small time frame there, we had 295 COVID-19 cases early in our pandemic, which was not that much now compared to where we are today in relation to the number of cases that we were seeing with the Omicron variant. But during this time, 81 cases during this time were born after 1990. And essentially, based on those 81 cases, in New York State, in the US, we have an immunization information system. And that system basically records all childhood immunizations, so we can have easy access to see what each person was given. And it's very useful because it creates that digital record for that person. So we use that system to determine the HPV vaccination status of these 81 individuals born after 1990. We also utilize medical records and patient interviews to ascertain the various different symptoms at onset. These are all confirmed cases. So we interviewed every one of these people. We had a very in-depth questionnaire that we did, and we collected a lot of different variables. So we looked at the symptoms at onset and symptoms prior to case interview or hospital presentation. And then based on this information, we used a comparison of symptoms and severity of illness in vaccinated and unvaccinated groups based on the HPV vaccination status. So our initial results based on this, the HPV vaccinated group was statistically significantly less likely to experience a cough, muscle aches, and fatigue. Later on in the presentation, we'll kind of show you all the symptoms that we actually collected based on our interviews. And we also figured out that the HPV vaccinated group statistically significantly was more likely to experience no symptoms at all. So the people that were actually vaccinated with the HPV vaccine. Okay. So just a little bit of background. Probably no one knows where we're located, but we're located in New York State, very far from New York City. As you can see the map here, we're up actually much closer to Canada than we are from New York City. We are in our very rural county for New York State. Our county population is about 57,000 individuals. We're halfway between the two urban centers of Buffalo and Rochester in New York State. So we have a very unique population and kind of geography in relation to kind of what we look at, what we see. But so with that, we kind of went to a timeline in regards to the beginning of the pandemic. Obviously, in 2019, December, they started identifying the pneumonia of unknown etiology in China. In January 2020, cases were eventually identified outside the US. And March 1st, 2020 is when we kind of ramped up here in relation to in New York State in the US. The first case was identified in New York City on March 1st, 2020. for COVID-19. On March 7th, so that the next case was identified north of the city and called the Hudson Valley. It's off the Hudson River area. And then on March 12th, it kind of made its way, well, first, I guess, identified its way March 12th, 2020 in Rochester, New York, which is about, I don't know, 30 miles away from kind of our city center here in Genesee County. On March 15th, the first case was identified to the west of us in the next urban area of Buffalo, New York. And then on March 17th in Genesee County, that's the day we first got our first confirmed case of SARS COVID. And then we kind of progressed through this little period here based on this journal article all the way up to October 20th. That's when we kind of ended our data collection period. The reason for that was we didn't move on is we're a very small health department and our resources we didn't have enough resources to keep continuing on this this analysis. So after that, our cases started to really rapidly increase. So it just took a lot of our time away. So kind of some of the early epidemic trends based in Genesee County, New York. Between that time frame there, 2 cases reported symptom onset on March 7th, 2020. And they represented our earliest known cases in the county. 347 positive test results we had during this time frame. Self-reported dates of onset peaked from March 19th through March 23rd, representing our kind of our first wave of our pandemic locally here in the western part of New York State. The single peak day during that time frame was April 7th with 12 cases, which seems like nothing now compared to what we're seeing currently with definitely with Delta and Omicron. But cases began rising again in September 2020 at the beginning of the second wave. We didn't have any variants of concern, obviously, at that point. And no COVID-19 vaccination was approved in the US during the time frame of this analysis. So why did we look at kind of, looking at different vaccines that might have created some sort of cross-reactivity? Well, early in the pandemic, as probably most public health professionals, we were just trying to figure out all we could about this virus and, spent a lot of nights doing literature reviews and seeing anything out there. So lots of different vaccines have cross-reactivity properties with other pathogens. So we did find some research indicating that there is a potential there that the HPV vaccine could show cross-reactive to the NS2 protein with SARS-CoV-2, which has produced the antiviral immune response. Cross-reactivity and cross-protection for the HPV vaccine has been shown to produce T-cell responses. And in general, like I said, immunizations have shown cross-reactivity and cross-protection to antigens other than those contained in the vaccine that it's meant for. So based on, this brief literature review, we decided to determine if there was a potential for protective immune response. Since we have such great data here in New York State with our immunization registry, we can just pull all that information based on our confirmed positive cases.
So I'll talk a little bit about our methods now. We have 3 HPV vaccines that are available in the US. The first one, Gardasil 4, which protects against 4 strains of HPV, was approved in 2006. Cervarix, which protects against 2, those are the 2 most common causes of cervical cancer, that was approved in 2009. And then Gardasil 9, which protects against 4 original strains of Gardasil 4 plus 5 additional ones, was approved in 2014. They were originally approved for use in young women only, but they've increasingly been approved for use in men, and the upper age limit for their use has been increased over time. So starting in 2008, the New York State immunization registry that Brendan was mentioning became law that pediatricians have to enter in all of their vaccination information, including historical information, for patients who are less than 19 years of age. We've now been using that registry for COVID vaccinations for people of all ages, but originally it was really for the pediatric population. So it provides a very reliable source of vaccination information for individuals who are on the younger side. So we decided to limit our analysis to individuals under the age of 30, who we would be more certain to have their immunization records available in NICES. So in our case selection, we had 347 cases reported during that time period of March 17th to October 20th. We initially excluded 49 cases because they were residing in federal facilities, so we did not perform case investigations on them. We have a federal prison in our county, which we don't do case investigations there. And then there's also a federal nursing home facility that we don't do case investigations in, because that's the United States government's job to do that, not our county officials. So of the remaining 298 cases, we identified 81 who were born in 1990 or more recently. So individuals who were about 30 years old at the time or younger, and we could be fairly certain that their records in NICES would be complete and up to date. So comparing these individuals, we had a vaccinated group of 45 and an unvaccinated group of 36 based on NICES records. The vaccinated individuals were on average a little bit younger, probably reflecting the fact that males were more able to get vaccines sort of later on in that period. So older men were less likely to have been vaccinated. Based on the racial breakdown, the racial breakdown is somewhat similar. Unvaccinated were more likely to be Latino or Hispanic or Native American, and the vaccinated group was somewhat more likely to be Black or African American, or to say that they are more than one race. The sex was quite different. Females were more likely to be vaccinated than males. In analyzing our data, we used the Fisher exact method and found that the HPV vaccinated group, as Brendan mentioned earlier, was statistically significantly less likely to experience cough, muscle aches, or fatigue. And that overall, they were also statistically significantly more likely to experience no symptoms at all. Almost every single one of the unvaccinated individuals experienced symptoms, but a significant minority of the vaccinated individuals experienced no COVID symptoms. And because cough, muscle aches, and fatigue are very common COVID symptoms, and they were some of the most common symptoms that our cases reported, the fact that there was a significant reduction in the incidence of those symptoms would be particularly impactful for individuals with COVID. So here's just a quick look at those three individual symptoms, along with whether folks were symptomatic or not. The green bars are the unvaccinated individuals, and the blue bars are the vaccinated individuals. And we have our p-values there below. And this is a look at all of the different symptoms that we interviewed all of our cases on. We interviewed them for symptoms at onset and also symptoms over the course of their illness up until the time that they were interviewed, which was typically several days, sometimes as much as a week or more into their illness. So these are all of the symptoms that they reported at any time during their illness up until the interview period. For a few cases who had sadly expired before they were interviewed, we used medical records to ascertain what their symptoms had been prior to their death. So you can see the statistically significant symptoms highlighted in blue over on the right hand. And on the left, you can see a list of all of the different symptoms that we interviewed for.
Oh, I think Jordan has his microphone on. If you could just mute that, he's getting a lot of feedback on that.
Okay. So our conclusions really were that obviously this is a small group of individuals, and that our findings should be really looked at, and we should attempt to duplicate them, or other researchers should, and investigate it in a larger population to see if HPV vaccine does indeed produce some cross reactivity and cross protection. Another thing of note that has obviously arisen since then, this was ancestral SARS-CoV-2. So we've had a number of variants of concern that have arisen since then, obviously, and continue to arise. So whether or not that cross reactivity and cross protection would still be found in the Omicron era is something that would be an area for additional research. And it would also be helpful to have additional laboratory studies to see if there's cross reactivity in vitro of the HPV virus, where T cells naturally recognize processed and presented epitopes from the SARS-CoV-2 infected cells. So obviously we are not at all advocating against use of the COVID-19 vaccine or any of the vaccines. We're strongly support it, and our colleagues spend a lot of time vaccinating people and have for the past over a year now. But obviously there are people who choose not to get it. There are people who are unable to have access to it, especially in other parts of the world. So it may be of some use to find out if there really is potentially a reduction in symptoms in individuals who are able to get at least the HPV vaccine. We discussed a little bit limitations of the study, the small sample of data. Another limitation is that some providers may not have followed New York State requirements and may not have input historical vaccination data into the NICES immunization registry the way they should have. So it's possible that some individuals were counted as unvaccinated when they truly were vaccinated. And also we discussed that this is, ancestral SARS-CoV-2, and so we don't know if this would hold for any variants of concern. And I just want to acknowledge all of our co-authors on the paper who are listed here, as well as all of our colleagues at the Genesee County Health Department who were absolutely instrumental in investigating all of these cases and the many thousands that followed.
Thank you.
Okay. All right.
Thank you so much for the wonderful lecture. Absolutely stunning and amazing information received from this presentation. And I would like to ask if any participants are eager to ask any questions regarding this to Dr. Redden and Dr. Emily. We can have an interaction sessions after all the series of lectures. So thank you so much. Thank you so much. Let's move on to our next lecture session by Professor Ashok Ratan from India, Omicron and Update. Thank you so much. Thank you so much.
Thank you.
So Professor Ratan, the stage is yours.
Dr. Ratan will be joining in just a moment.
I think Professor Ratan has mute here. Okay, he's here.
Right. Share screen. Can you see my slides? Can you see my slides?
Yes, Professor. Yeah,
All
it's
right,
visible.
so we'll talk about Omicron, and I would suggest there's evidence that they may be beginning of the end of the pandemic. You would all recall that it was on the 31st of December 2019 that WHO was informed that there was a cluster of pneumonia caused by a novel coronavirus in Wuhan, and by the 10th of January 2020, one full sequence of this RNA virus was available in public domain. Next day, 5 more sequences were available so that people could get busy on detection methods. The RNA virus had a length of nearly 3,000 base pair, and it made 4 structural proteins. So various labs focused on different structural proteins. And in India, there was only one lab in January which could detect coronavirus, but by November or thereabout, 3,020 labs can do PCR and about 29 labs can do sequencing. Along with that, the manufacturers worldwide got active and made many diagnostic kits available, both for molecular biology as well as antigen and subsequently serology. And I think the regulators have also responded quite quickly by making many of them available as EUA. The antigen has sometimes been promoted as a replacement for RT-PCR, but this is from PATH submission, which said that out of 128 antigen tests, only 7 would confirm the results. So the RAT test, the rapid antigen test, does not seem to be at this moment the right method to use. In the RT-PCR, they used, in the molecular biology, they use RT-PCR, the transcription mediated amplification, the isothermal RT-LAMP and CRISPR, and the antigens or the genes that they focus was ORF, ORF1A, ORF1AB, RDRP, E, N, or S. And as the volume increased, then they had systems available for automated handling also. It's also been suggested that since this is an RNA viruses are subject to mutations in every multiplication. Though SARS-CoV-2, also an RNA virus, the mutation it accumulated in the first year was about 1 mutation per month. Influenza, on the other hand, picks up 2 mutations per month, while HIV picks up 4 mutations at the same time. Because SARS-CoV-2 has an enzyme, XON, which has proofreading abilities. Mutations, however, occur throughout the length of the 30,000 amino acids, 30,000 base pair, but it is the mutations which occur on the spike protein, varying from 1273 amino acids, which actually lead to a lot of changes. And it was one such mutation where it was D614G, which changed in its ability to spread. And by May 2020, that was the dominant variant available. Then in Brazil, though they had suffered from though they had suffered and recovered from the original infection, there was another resurgence of infection. And when the resurgence occurred, they felt that maybe one of the reasons given was that maybe it's a mutant. So the theory about mutant started somewhere from Brazil and also from UK at the same time, which had Nelly mutation, N501Y, where again it could spread more. But the E484K, the EX mutation, where glutamic acid is converted into lysine, with some immune escape, led to not only more spread, but more fatality. WHO as well as CDC then brought out a definition for classifying variants. They had variants of interest, variants of concern, and variants of high consequence. And the possible consequences of emergence of variants could be increase in replication of the virus in the cell, leading to increased viral load, increased receptor binding, increased virulence, reduced efficacy of treatment, increased reinfection, decreased neutralization by serum, and deletion of primer binding sites. It was also decided that instead of having the place where they were isolated, labeled as those strains, these variants should be given Greek alphabet, starting with the United Kingdom's alpha, then South Africa's beta, Brazil's gamma, and India's delta, etc. And by the beginning of November, we had till mu as the variants in different parts of the world. It was also, since some people would die and others survive, the reason was determined in a study in USA, where they found that if neutralizing antibodies were produced by 14th day of infection, the person would survive. If the neutralizing antibodies were not available, then that might act as in fatality. To find out how much neutralizing antibodies was required, neutralizing antibody, the antibodies to anti-spike were purified and injected into groups of monkeys. One group received 250 milligrams per kg body weight, another group received 25 milligrams per kg body weight, and the third group got 2.5 milligrams per kg body weight, and another group was did not get any. Then all of them were infected. Only the animals who had 250 milligrams per kg body weight did not show any infection. When they did not show any infection, the antibody levels was anti-spike was 400, anti-RBD was 100, and neutralizing antibodies was more than 50%. So that should be the threshold for protection. So the way of explaining this would be that spike proteins is what binds to ACE2 receptors, and the neutralizing antibodies will block this union by binding to spike protein. Then all the in the meantime, spike protein was chosen as the antigen which would be used as vaccine in many of the vaccines, except for a few where they used whole cell inactivated vaccine. There is a lag period once the antigen or infection occurs. There's a lag period from primary response, but after initial high level, there is a decline. And when the decline occurs, then after the primary response, you have to give a second dose to have the secondary response. Again, when it decreases, then you will give a booster. This is normal immunology. It was also seen that those who got only vaccines had less robust response than those who had COVID infection and vaccination. The hybrid response seems to be better in protecting them. In studying the efficacy of vaccine, we need to look at infection, hospitalization, and ICU admissions. And all the vaccines were effective in preventing infection, but this protection was not complete. They were more effective in preventing hospitalization and death. But it was observed in Qatar and in Israel initially that over the time, there's a decline in protection against infection, though protection against hospitalization and death remained even after 6 months. This decline was with all approved vaccines. So it was not restricted to one type of vaccine or the other, but all vaccines had a decline. But when you give a booster, the efficacy of booster in preventing infection against those who did not get a booster was very clear. In the meantime, the Delta variant, which started from India from the 1st of April till May and caused a lot of havoc and deaths, spread to different parts of the world and became the dominant variant which was circulating. Though people were keeping an eye on not only Delta, but also on Lambda, because Lambda, which was in Peru, had more affinity for ACE2 binding than any other coronavirus, and it had no neutralization with monoclonal antibodies. And it was the major cause of death in Peru. So people were surprised when a report came from South Africa about a virus which was spreading very rapidly. It was collected from persons infected in Botswana and South Africa, and the person did travel to Hong Kong before it was reported to WHO, and WHO quickly labeled this as Omicron. The surprising also part was that they'd agreed to give it as Greek letters, and A to mu was already given, but nu and Z were skipped, and we had Omicron as the new virus variant. The specific property of this variant was that it would spread very quickly, and as you notice here, it spread much faster than Beta and Delta. And it had about more than 50 mutations in the whole genome. Some of the mutations were known, but many of them were unknown. There were also mutations near the monoclonal antibody sites, and so many of the commercially available monoclonal antibodies became useless. And when they analyzed it more to compare it with alpha, beta, gamma, and delta, they found that it had taken a few mutations from each one of them, but it seems to have a different lineage, and there is distance in the genome. There was genomic distance between delta, alpha, beta, and gamma. The mutations are continuing, and this Omicron can now be divided into 3 groups: B1, BA1, BA2, and BA3. Another surprising thing for the first time was that this genome also has an insertion which is required for human coronavirus A 2 to 9E, which is a commensal virus present in the upper respiratory tract. So this was an insertion in there's deletions, but along with deletions, there is also an insertion from a commensal coronavirus. And in the recent past, this has spread to nearly all parts of the world. When we come to clinical features, we find that while Delta variant was more of a lower respiratory tract infection with pneumonia persisting, predominant in Omicron, it was upper respiratory tract infection, which is the predominant feature. And people complain of scratchy throat, congested nose, high fever, body ache, and weakness. Because the treatment and the course between Delta and Omicron are different, it is important to differentiate it from Delta, which was still prevalent, but wherever Omicron has been detected, soon it replaces Delta from the location. In Omicron, night sweats, appetite loss, nausea are also features, while there is no loss of smell and taste. Another thing that they noticed that in clinical presentation, when Delta came, the infection rate as well as the admission to emergency admission and deaths, they occurred nearly together. On the other hand, when Omicron has come, the cases have been tremendous. There's been tremendous increase in cases, but the admissions are nearly 1/4 of what happened in Delta, and deaths are 1/10. The reason why this has happened is this is more Omicron is more of an upper respiratory tract infection rather than Delta, is because of this study which was done in Hong Kong, and which indicated that Omicron has 70 times more a level of growth in the bronchi as compared to the cells. So it doesn't seem to enter the parenchyma as much as it divides in the bronchus. So it's more of an upper respiratory tract infection. Looking at that, CDC then revised the isolation rate. I think part of it was also to make sure that healthcare workers get back to work rather than take 10 days off. Because there's evidence that the infection from Japan, there was evidence that infectious period lasts at least 9 days. It's not 5 days, which is enough. Infection is there for 9 days, and from the 10th day onwards, there's no infection. There was also in Danish household, when they looked at it, the secondary attack rate, we found that those who were non-vaccinated, unvaccinated, they were more likely to be infected. Next were those who were vaccinated, and finally the least susceptible were those who had booster. When they compared between Omicron and Delta, they found that the secondary attack rate in Omicron, which has immune escape, was much more, indicating that it is because of immune escape that there is increase in transmissibility. They've also seen that that any infection with any of the coronaviruses would lead to even cross-neutralizing antibodies, and infection with Omicron would also lead to cross-neutralizing antibodies, which give protection against Delta. By this time, papers from South Africa started coming, indicating that the Omicron was affecting younger age group and was milder and would have less hospital admission, less stay, and mortality was 1/10 of what it was. This was also confirmed in animal experiments from across the globe, that Omicron is a milder version of Delta. And though the neutralizing antibodies were not working against Omicron, there's evidence, and among the commercially available monoclonal antibodies, only Strovimab was the one of GSK's. Strovimab was the only one which was effective, all others being not effective anymore. And the criteria for hospitalization was oxygen saturation below 94%, respiratory rate over 30 per minute, CRP more than 50 nanograms per ml. But they found that the need for hospitalization is much less, and many of the patients in India are being treated at home. There is also molnupiravir which is a nucleotide analog, which has been made available for oral use. It sterilizes the upper respiratory tract from the virus in 4 days of treatment and would help in decreasing transmission of infection. But it has teratogenic effects in the rats, and that's why people are reluctant in using it. There's another drug which is available, which is not available in India, but has been available in US, is Paxlovid, which again is a nucleotide, it's a protease inhibitor, and it is given along with a drug which will decrease its metabolism by P450 enzymes. And it is very effective. About neutralizing antibodies, I've already told you, most of them will not work except for sotrovimab. And so Paxlovid has 89% effectivity. The monoclonal antibody has 85% effectivity, and remdesivir, when given within 5 days of RT-PCR positivity, has also good effectivity. Overall, it's been confirmed that though the infection has been tremendous all over the world, the death rate is much less. And even in America, where after the holidays, there's a big spike, but there's no spike in death rate. And it appears that this is partly because of cross-reacting T-cell response, and T-cell response with ancestral and Omicron is robust, and it is T cells, both CD4 and CD8, which seems to provide protection, which neutralizing antibodies are not. And cellular immunity seems to be cross-reacting against Omicron. And so it's been suggested that even though 2 doses of the current vaccine may not give adequate protection, if a booster is taken, it gives a better protection. And this is a slide given by Pfizer, which indicates that if from the original, if you have taken 2 shots, you are still susceptible to infection because the protection level is less. But if you take a 3rd shot, this will increase 25 times. Vaccination of the children is also effective. Once you start vaccinating the children, then the transmission of infection in the society, in the community, decreases. Lastly, about the lab diagnosis, Omicron they are associated with deletion mutations, S6970, which is the site where S gene binds, leading to S gene failure. But if you're using a kit which detects multiple genes, which normally we use, then you can still pick up the presence of coronavirus. Initially, we had started using TACPath, which has ORF1ab as well as S gene and N gene. And when mutation, here you'll find MS2 is used as a negative marker. And so only if that is the only one which is amplified, that would mean that it's a negative report. On the other hand, if all the 3 genes are amplified, this will be a positive report. For a positive report, at least 2 genes must be amplified. On the other hand, and it was also decided that if you have the CT values less than 24, that means a person is infectious. Over 24, the person may just be having a remnant of RNA. When you have only ORF1ab and N gene amplified, this will indicate that there's S gene target failure, but it will be reported as positive for SARS-CoV-2. So these are the isolates which are then sent for sequencing to confirm the presence. But as I indicated earlier, that BA1 has S gene mutation, but BA2 and BA3, the variant of Omicron, do not have. In this, as you notice here, that if their mutation is in the primer binding site, then there would not be any amplification of the gene. The other one can be at the probe binding site. If there's mutation at the probe binding site, then the probe will also not bind, and still you might get a negative result. There have been tests, so most of the tests which are multi-gene will be able to detect the virus, but Tata MD has developed an OmniShow test, which looks at S gene target failure, but also looks at a probe which is specific for Omicron mutation and also RDRP, so that they can indicate whether a person is suffering from Delta or is suffering from Omicron as PCR. There's a newspaper report indicating that 96% of the beds occupied by oxygen beds occupied in Mumbai are by those which are non-vaccinated. So two things that we can do to protect against Omicron. One is that we take a booster dose, and the second one is that we wear a mask so that the transmission from one person to another person decreases. Deviation from COVID appropriate behavior is currently the biggest variant of concern. But if Omicron turns out to be only upper respiratory tract infection with its higher infectiveness, it will infect all those who don't wear masks, and the endemic infection will cause endemic infection and end of pandemic. I thank you for your attention.
Thank you so much, Professor, for such a wonderful and a lovely presentation. It's really a wonderful and a knowledgeable presentation. But here I would like to convey one message from Professor Pranab Bhattacharya, is willing to have some questions. And Professor Bhattacharya, I would like you to clarify your queries to Professor Ratan. So, sir, could you please clarify Professor Pranab's some queries? Yeah. Hello, Professor Pranab.
Yeah.
I think, sir, you were having some queries.
I think, let me come in. Yeah, I think Professor Pranab has some few questions for Professor Ratan.
Yeah, sure.
Yeah, he said the first one is, what is your view of giving Molnupiravir for Omicron and Delta VOC?
What is your
view?
About what?
Molnupiravir, the drug Molnupiravir.
That is the new drug.
Yeah.
The drug is effective, but the effectiveness seems to be only 30%. And so people have restricted it to those over 60 years of age, and not to be given to, it should not be given to children below 18 because it inhibits the growing cartilage. Then, since it has mutagenic effects in rats, and we have not studied the effectiveness, whether this will translate into any damage to human beings or not, it's been best that it should be restricted to only those who are at increased risk of progressing from mild to moderate infection. In that case, it should be given early in the first 5 days, because it's an oral capsule. 4 capsules need to be given morning and evening. So I would say that yes, it should be used, but under supervision of the doctors.
Okay, thank you. I think the second question is, for how long will one have high levels of antibodies after taking a booster shot of any of the vaccines?
I think the previous experience has shown that after you take the second dose, then it lasts for at least 6 months. So if you take a booster dose, I would expect at least 6 months it will be there. And if a person has got Omicron infection, then that will also act as a booster. We have noticed that if there is a hybrid infection and vaccination, that gives much higher protection than only by vaccination or only by infection.
Okay.
Till a new variant comes into the till a new variant comes into appearance, we would feel that now the pandemic is about to end.
Thank you so much, Professor, for giving us a wonderful knowledge about it. Thank you so much once again. So I would like to invite now Dr. John Oladejo from Nigeria for the next presentation on COVID-19 pandemic, the journey so far. So let's welcome Professor John Oladejo from Nigeria. Thank you so much, sir. The stage is yours.
You hear me? Hello?
Hello, doctor. Yeah, hello. Hello.
Yes. As a matter of fact, I really want to talk about our I want to talk about the strategy, the fourth wave, and the strategy we have actually adopted in Nigeria to really combat it. So I will like to share my I would like to share my presentation. Hello.
Yes, Professor, you can share the screen, and we would like to, and it would be kind of you if you kindly just turn on your camera. It will be highly appreciated.
Okay, so show my camera. Okay, let me first of all share the screen first so that I'm trying to look for my presentation. I'm coming. Yeah. Just give me short, very small time to do that. Okay.
Yes, Professor.
Mm-hmm. I couldn't find it on the window. I don't know whether I have to start talking about it. Why I look for it on the window. Oh my God. Zoom.
Are you trying to locate your articles?
Yes, I can't find it on my. I'm just trying to see if I can just find it on the screen, but I can't find it. Okay. Can I send it to you? Through your WhatsApp? So that you can.
Send it on to what is the name? Through link, is it? But is it possible to talk through it?
No, just yes. Let me just talk through it.
Yeah,
I can send it to you later to share. I'm so sorry about that. Mm-hmm. Okay. So I want to talk about. I'm very sorry for this. All these complications. I want to talk about the COVID-19 pandemic response in Nigeria, the fourth wave and the testing strategies. My headline will be COVID-19, the background, which we all know, the current situations updates in the fourth wave, the summary of the response, and the fourth wave testing strategy, then the sequences update, and then our next steps. As a matter of fact, the first fatal case of COVID-19 was actually reported 2 years ago in China. That was 11th of January 2020. And the WHO declared it as a public health emergency of international concern on the 30th of January 2020. That's a few days to 2 years. Then the pandemic was actually declared on the 11th of March 2020. So in Nigeria, the first confirmed case was on the 27th of February 2020. The fight against the COVID-19 has taken several twists, turn and dimensions. We can say marathon rather than a sprint. The wave, as in many countries, Nigeria has experienced 3 waves and are currently on the 4th wave. So the current situation updates, as at 16th of January 2022, we have 250,929 cases with a 3 million tests conducted, and the active cases are 23,794. We have actually discharged 224,032, and the deaths 3,103. It would have been very nice if you see this epic cough. Let me try it again, because for you to really enjoy this presentation, I think we really need to show what we have here. So I'm just wondering why I cannot really see it here. I'm just wondering. I'm so sorry about this. Can you see it now?
Yeah. Yeah.
Can you see my?
Yeah.
Yes, yes.
Yeah.
I can see it.
It's clear.
Great. Thank you. So this is the national epic cough. So look at week 2 of 2022. You will see that we have the first wave around 27th, the second one around 4th week of 2021, and then we are having the fourth wave around 52nd, that's the 52nd week of 2021. And then when you look at the next curve, that is by my right, you will see that it's actually shown very well. In the last 3 months, the wave from 4th of December to 15th of January. So we have a very high bar around 24th of December. So you will all agree with me that this is the time where we have Christmas Eve. So many people are moving from one place to another, visiting people here and there. So the cases have actually declined by 46.2% over the past week. So the cases trend with the states in the last 4 weeks. Then over the last 4 weeks, we have about 11 states that are actually declining from this slide. They're increasing across 9 states. Those are the ones that are red. There's those ones that are stable, so similar across 8 states. Those ones that are yellow, but there are some that they are too few for any trend in any direction. So those are white. So we have about 36 states in Nigeria, that is 36 states, plus 1, that is FCT, and we're about 200 million in population. So this slide is showing that a weekly number of deaths through cases. By my left, that is the trend in week deaths. We have 38 deaths reported in the past week. The case fatality ratio for week 20, week 22 is 0.9%. And then when you look at the right side, you see that the case fatality rate is actually shown here, and is also around 3.5%, that is in total. So what did we do during this fourth wave? So we have to go into retesting, because that's the only thing. It has been established that we have a community transmission. So we really need to go into upgrade of a mass testing. And when you look at it cumulatively, by January 2022, the combined tests we have had so far was 3,991,391. The PCR alone is 3,249,560, while the RDT is 741,831. So you will agree with me that we have more of testing with PCR, which is a real confirmatory test, than RDT. Our RDT is actually used in hospital setting, in prison setting, in the school setting, whereas PCR are actually used in all the laboratories. We have about 140 laboratories scattered all over the country, where people can just go and get tested. And we have developed some strategy to ensure that at least everyone should be able to know the status in terms of COVID-19. So this particular slide is just showing the test and test positivity in recent 2 weeks. That is week 52 of 2021 and then week 1 of 2022. So if you look at it critically well, you will see that we have 5,000 tests in 2 states. About 2 states had more than 5,000 tests in the last 2 weeks, whereas 8 states have 1,000 to 5,000 tests. There are 16 states, 1,000 to 100 to 1,000 tests, and 10 states, 1 to 100 tests. It's only 1 state that have 0 tests, and that is UB State. And then the reason why we couldn't get anything from UB State was because of this insurgency. Our technical officers, they couldn't really penetrate that place because of the security issues around that area. So this slide is just showing us the trend in test positivity as at week 2 of 2022. The trend in PCR's only test positivity, there's increase from 12.5% in week 2021 to 15.9% in week 2022. So using PCR, whereas if you had the two together, both PCR and RDT, the test positivity rate is 6.3% in week 2 of 2022. So this is the summary of our response for the 4th wave. We scale up early detection and confirmation of cases, then enhance surveillance and screening of port of entry, upgrading and optimization of lab capacity in all states, continue training and retraining of human resource, heighten surveillance activities in communities and health facilities, intensify genomic sequencing capacity and activity. So we maintain capacity to effectively manage cases by equipping and reactivation of treatment centers. In fact, I was in Port Harcourt last week, to really do sort of advocacy. And then we have some new labs that have been launched, especially in Port Harcourt, Kano, and Lagos. This is where we have high densely populated area. They ensure sufficient and trained human resource, map out such capacity for development, ensure availability and deployment of adequate medical consumables to states, continuous training, assessment and monitoring of compliance to IPC. IPC is Infection Prevention and Control Measures. So the coordination and communication with Nigerians was very, very key too. As a part of our response, we established national and subnational multisectorial EOC, IMS, which they actually meet regularly. We have 24/7 Connect Center for the public, where people can ask questions, and we have a short code 6223. Anybody can access it. You don't need to pay any amount of money. It's just free to, it's a toll-free number. The automation of public emergency operations center. We have done this in 33 states. So we still intend to do the remaining 3 states before the end of February. Then reviewing and disseminating response guidelines and protocols, regular communication with the public. We always release, we have press release almost every week for people to know what is actually going on and then to be updated. And then we have media appearances. I did one about 2 weeks ago, and we have people that go to all these media houses to tell the public what is actually going on. Then promotion of the use of non-pharmaceutical intervention was very, very important. That is a public health social mobilization system. And behavioral change, communication, and community engagement on vaccine hesitancy. You know, you all agree with me that there was always vaccine hesitancies almost everywhere. So we have actually done a lot of survey researches on this, and we're able to tailor our communication messages towards this. And there have been improvements in this area. There is communication messaging, surveillance and laboratory. These are major things we're doing. For the facilitation so far, as of January 17, 2022, the total clients vaccinated is about 12,997,744. Proportion vaccinated is about 10.2%. Actually, we're going to 40%. So we still continue to inform the public on the need for them to be vaccinated. So some people were saying that they're still coming down with disease. Why the vaccination? But we need to explain to them that when they're vaccinated, there's always improving their immunity, so that if they are reinfected again, that will not be as severe as when they were not really vaccinated. So these are the things we have been doing in Nigeria, and this is total claims to reach as at 17 of January 2022. For each of the states, we have 36 states plus 1, and each one has actually vaccinated more than 185,000. Some are less, depending on the number of health workers that are involved. So for the fourth wave strategy, the PCR over 120 molecular test laboratory all over the country, and we are still counting. I just mentioned that one. The scaling up of AG-based rapid diagnostic test, which is ongoing, and we continue to train health workers. We continue to expand, and we continue to look for all these closest areas to ensure that we test as many people as possible. Then cascading of training across the state. We're not going towards SGA and then facilities. We have committees that are working on that, and we have monitoring teams that are scattered all over the country to ensure that we get all our information in a very short period of time. Then further decentralization of testing sites. This is what we are expected to do, and we have even started doing it. The review of the national testing strategy, then a facility visit testing. You know, if you don't visit them and then monitor them, they may not be able to do the right thing at the right time. So we have actually set up a different monitoring team that will go and check them. We're even doing auditing now for all the private laboratory, because this 140 molecular laboratories is not for Nigeria, federal government alone, for government alone. Then we have private sector too that are involved. And then we need to ensure that they have standard and they maintain that standard at every point in time. So testing and community close setting, I've already mentioned schools, events, large gathering, offices, and so on and so forth. Then we target national and states, which I've already mentioned. There is sequencing of all positive samples, because we really want to know what the type of sequencing we're dealing with, whether it's Omicron or any of the mutants. Then plan to optimize other testing laboratories for sequencing capacity. You know, this is where we don't have enough, but we have already set some work in motion to ensure that we are able to at least train some of the health workers in the laboratories, some of the laboratories to be able to do sequencing. The external quality assessment program. So WHO and the African Society of Laboratory Medicine, they have been contacted and they are really working with us. Then we have what we call inbound testing protocol. So COVID-19 PCR tests to be done within 48 hours of departure for all travelers. It is a guideline that everybody must maintain. Then post-arrival day 2, COVID-19 PCR test for all travelers. Then self-isolation for 7 days for partially vaccinated and unvaccinated travelers. And on day 7, post-arrival negative COVID-19 PCR test is required for exit from isolation. So these are already set in motion, and any passenger, especially those ones that are coming from highly infected area, they have to obey it. Then fully vaccinated means at least 2 weeks following 2 completed doses of either AstraZeneca, Pfizer, Moderna, or a single dose of Johnson & Johnson vaccine. Then partially vaccinated, just when you have 1 completed dose of those vaccine as mentioned. So this is the trend of the inbound as at 5th of December 2021. We can see that there's a new testing protocol that was actually enforced from that period up to now. And the red is the net positive, the green is negative, and then the test positivity rate at the trend you can see, that is how it is rising up and down, and then it's started from week 48, and then at week 1 of 2022 is now coming down gradually. That is the test positivity rate trend as recorded. So this particular slide is showing the positives by departure country. You'll see that we have 414 cases were actually reported in week 1 from 51 countries. So this one will alert us on what we need to do. People are coming from United States, United Kingdom, India, United Arab Emirates, and so on and so forth. So I want to quickly talk about the variants detected in our country. Up to date, we have 4 variants of concern detected in Nigeria. We have Alpha variant, Beta, Delta, Omicron. Of these, only Delta and Omicron have actually gained enough community transmission and become the dominant circulating variant. Other variants continue to circulate in the community, such as Eta, B11, 318, and so on and so forth. So if you look at it, this is genomic surveillance. So this slide is showing positive inbound sample sequencing updates from week 7 to week 52. Those variants that were actually detected in the country. So for Omicron, this is variant of concern. It was first reported on 1st of December 2021. So as of 11 January 2022, 34 genomes have been detected and uploaded on GZ from Nigeria across different states. No cases of non-travelers have been found in Nigeria, confirming local transmission of the Omicron in Nigeria. So the recent surge in the number of COVID-19 cases in Nigeria is actually driven by the rapid spread of Omicron variant. So the number of sequencing per state is actually depicted here on a pie chart. The major states that actually involve are FCT, Ekiti, Akwa Ibom, Kano, Kwara, Niger, Kwara, Nasarawa, Rivers, Lagos, Abia, Ondo, Benue, and the 2 states. So those are the major states that have been affected. So what is our next step to ensure that we continue to contain the outbreak and then to interrupt the community transmission engagement? We have actually planned, and it is equally ongoing, to engage the states, the partners, and all stakeholders. So we're having a series of meetings with all the state epidemiologists across the country every week. So every Friday, 5 p.m., we have virtual meeting where we review what we have done in the last 1 week and then see some of the challenges and then resolve them. Then our partners who are actually supporting us, they always come for that meeting too. Then continue scale up of all the activities around the surveillance, the lab, case management, risk communication, and IPC. So we have different pillars. So we are using IMS system to be able to coordinate all this. Then we are equally intending to increase sequencing capacity so that we'll be able to track down all the variants of concern and even variants of interest, as well as to really, track down all the passengers of interest coming into Nigeria, as the case may be. Then finalization and implementation of pre-test testing strategy. We have just developed another strategy which has been submitted to the Honourable Minister. So immediately this is approved, then we roll it out, and we are going to get to the air facility, not just to the local government alone, but to the air facility. So we are involving Community Development Association, we're involving all NGOs, we're involving all the local health facility to ensure that every person in that community are given the opportunity to be tested. And then we have health volunteers who are actually living in the community, and they'll be able to detect whoever that has that symptom and be able to ask the person to go to the nearest health facility for this. We're equally encouraging vaccination, and we're addressing vaccine hesitancy. Thank you very much for listening to me. Over.
Thank you so much, Dr. John, for the wonderful lecture. And it's really a very encouraging session. But I would like to convey one message. One of our eminent delegate, Professor Pranab, is having some queries to the speakers. So Professor Pranab, it's my honest request that if you can clarify what you want to ask Professor John and Professor Ratan once more. Yeah.
Hello, am I audible?
Yes, sir.
Hello?
You are very much
Yeah.
audible. Yes, sir. Yes, sir, you're very much
Yeah,
audible. Thank you, sir.
I
Thank you, sir,
wanted
for
to
your
ask.
precious
I
presence.
wanted
Yeah.
to ask one thing that in the France, a new mutant variant has come out, IHU variant. How much is possibility of that VOC to spread globally in the next? Number one. And number two is that in Nigeria, what vaccine Omicron, as Omicron is much more, as has been told by the speaker, that from 1st December, Omicron is the most important infection. What the vaccine against the Omicron is given by the Nigerian government? Is it an Omicron specific or non-specific like Tedox vaccine or by the BNT vaccines or like that?
Okay, thank you very much. I think it's Professor Yaro that will answer the first aspect of the question. But the second one, we are not actually specific because we still believe that other variants are still in circulation. So we use a non-specific Omicron for vaccination. So we are still using Johnson & Johnson, AstraZeneca, and other vaccine. Over.
So, in fact, there is no Omicron specific vaccine because, as you know, Omicron came
Right.
into prominence only on 26th November.
Yeah.
So,
Yes.
you're relying upon cross reaction,
Yeah.
and any vaccine will work. Any vaccine will work. So, and there is evidence that if you have heterogeneity of vaccination, it will give you better immune response.
Right. Professor Ratan, I want to tell you that in India, actually, the first vaccine was given Covishield or Covaxin, or mostly the Covishield vaccine. Then second vaccine is given by the second dose is given by the Covishield vaccine. But the booster vaccine, what is needed is some other vector vaccine. But the government is giving the Covishield vaccine. I think that the same Covishield vaccine will not be much more able to raise the immune status, particularly the antibody status of the neutralizing antibody status. Rather, if they would prefer some other vaccines, I think that this heterogeneous vaccine would give a better antibody responses for the Omicron and other VOCs. What do you think of it?
Yes, sir. Of course, now there are 5 vaccines which have been approved. So, but only 2 of them are available. Covishield and Covaxin is the one which is readily available and in plenty supply. But from administrative point of view, I think they have said that whatever was taken earlier should be given. It's more administrative than scientific. But
right, that what I want to tell that why not the government is opening the market of the other vaccine to come, and those who have got the ability to purchase, they can give that. But the ICMR is not doing that thing.
I think it's more administrative than on
Yeah,
scientific. And at this moment,
like
we're going to have elections soon.
I
So,
think so.
and vaccines have been given free to everybody. So they didn't want to get into opposition, blaming them for profiting out of this calamity. So I think they want to continue giving free vaccines. And this has been run very well. We more than 1.5 billion doses have been given, and
right.
more.
That is right. That is okay.
Every day, lakhs of that means nearly 10 nearly 1 million doses are given nearly every second day. So it's been tremendous, the amount of work that has gone on in making sure that the cold chain is maintained, then the person, and you get your certificate after getting your second dose, or now, as they say, the third dose is known as precautionary dose, not as
Yeah,
booster dose, but they've
it
labeled
is a
that as
precautionary dose.
precautionary dose. And they've said it is available for all healthcare workers, anybody over 16 years of age, and of children between 15 and 18. But I think schools will open only when children from 5 onwards have been vaccinated.
Yes,
So
I agree with you. I agree with you. But the people are wanting, and the political parties are wanting to open the school very soon. I think that is a very dangerous for the group of 15 to 5 to 18
so
groups.
I think in this
It's a very
Omicron,
dangerous thing.
Omicron will infect everybody who doesn't wear mask. It is highly infectious. Once it reaches the home, then everybody in the home gets infected. So I do
I got
notice.
myself infected on 5th January in spite of having the 2 vaccines. And I was very scared.
Me
That,
too. I was infected.
I was very scared. And even my wife has been infected also very soon after I got the infection. Though I wear always N95 masks. And I stopped my attachment as a pathologist. In spite of that, I got infected. In spite, I always use N95. Always use
I
N95.
think, sir, the weakness would be when we are traveling in a lift, because if we travel in a lift, then we are in close contact in that close space for some time, and that is one weakness. Otherwise, I think we've been wearing N95 mask when in public, only taking it out when we are in our chamber alone. But the weakness is when we are traveling with the driver in a closed car, or we are in the lift. Those are the opportunities which sometimes, even if sometimes we open it, or we have a cup of tea with somebody. So we've stopped having community teas and lunch. Otherwise, normally we would congregate together and have lunch together. But now we have lunches in our own rooms, and tea also alone. So mostly it is webinars and Zoom meetings that we're having rather than physical meeting. But
may I ask another your opinion? I had the opinion, and I published it in the BMJ and also in the Science, that the possibility of airborne transmission of the COVID-19 virus. What do you think about it?
I think it is a possibility. It's more
It has to be
likely.
proved.
I think, see, when they proved it in guinea pigs, because they had the means, and they had infected guinea pigs in one room, then the air duct was there, and the guinea pigs in the second room got infected, and then they showed that it is through the transmission of air. Now we know that hamsters are the animals of choice, and that could have been proven because we had that discussion with the WHO, saying that whether it is airborne transmission or droplet transmission. Because if it is only droplet transmission,
That should be done.
then 6 feet is what you require for the droplets to fall down. But if it is airborne, then an empty room which has been occupied can also cause infection. And I think community infection is indicating that it is airborne. So you're right in that, sir.
Yeah, I also have some questions.
Thank you.
The first question goes to Dr. John. Yeah, so Dr. John, what are some of the challenges you encountered in Nigeria in dealing with like Omicron?
Yeah. Okay. Thank you very much, Prof. I actually mentioned it in my presentation. When we actually detected that we had Omicron in the community, the first problem we had was how do we get them tested? The people around. So that was the first problem we had, testing strategy. Then the facility, some of them were equally infected, some of the health workers. So we have problem in the sense that you get to a particular facility, you don't see anybody there. Most of them are already on isolation. So we really need to really start looking for the workforce. So those are the major problems. Then another thing is the testing capacity for the genomic sequencing. So those are the major problems. Well, with the help of government and then our partners, we have now developed a roadmap to be able to resolve those challenges. So we're working on it.
Okay. Okay, then Professor Ashok, this question is for you. My question is, looking at the way the variants of concern keep emerging, don't you think we should have a clear pathway, maybe every 3 months, 4 months, 6 months, we have to analyze the effect of those vaccines and if possible, develop new vaccines for the prevailing circulating variant?
The initial thought was that it is antibodies which are protecting. We know that IgG antibodies will protect against systemic infection, but not localized infection. So maybe what is required is a vaccine, nasal vaccine, which one of the biotechnology companies is making, if that can be fast forwarded so that nasal vaccine, nasal booster is available, and that would then prevent infection, which will then prevent transmission of infection. You have seen that there are now 2 oral drugs available, which will sterilize the nose and the throat of persons who are infected. Because what happens is that millions of people have been infected since this infection is infectious during the incubation period. So before a person becomes symptomatic and you test them, they are already infectious, and they are infectious for another 3-4 days after that. So if you can sterilize their nose and throat of the virus, then the prevention of infection would occur. So vaccine, and there is, now that we understand that neutralizing antibodies are effective to prevent systemic infection, but death seems to be prevented by cell-mediated immunity. And only now we have been able to start measuring cell-mediated immunity by looking at interferon gamma and TNF-alpha and IL-6 as a consequence of exposure to various antigens of SARS-CoV-2. And the antigens are more conserved, so that whether you have used one vaccine or the other vaccine, the vaccines with that, they seem to produce T cells which will give cross protection. So I guess what is required, and as you notice that 3 of us here have said that we are vaccinated and got infected, but I think you're also saying that, yes, it was a mild infection, while those who are in the hospital are those who are non-vaccinated. So that vaccine hesitancy, that is what we need to address and encourage persons by our actions to get vaccinated. As I indicated, that fully vaccinated persons also get infection, but then they get only mild infection, though they can transmit infection to others. But with the Omicron losing its virulence, I think it's going to transit into endemic stage. And so it is here to stay. It's not going to disappear as SARS-CoV had disappeared. You know, when it occurred in 2003, after killing about 800 persons, it just disappeared.
Yeah.
So there was no vaccine made, nothing. Preparation were ready for making a vaccine, but it wasn't followed through.
Yeah. So based on your paper, your presentation, when do you think the world should be bold enough and say, hey, enough is enough, let's come out?
I think, see, Africa is already saying that there are no deaths now. Or it is not, it doesn't make a person immortal, but that means the infection is not causing any no more increase in admission or death. India is saying today or tomorrow, I think Britain today mentioned that we are supposed to remove that, maybe 1 or 2 weeks too ahead of time. But I think they wanted to claim to be leadership to decide that no mask. I would expect that by 1st of February, schools might open. But that may again be 2 weeks too early. What I would be happiest if children are vaccinated by something like Covaxin, which is whole cell vaccine, which provides cross protection against any variant. The good point about Omicron is that it is replacing Delta. It itself is mild, but infection with Omicron is producing immunity against Delta, and Delta is being wiped out. Delta, which was a killer, is being wiped out and is being replaced by a milder strain, which is then likely to become endemic.
But I think one study was, I think, I've forgotten, either Greece or something. It was saying that they identify a combination of Delta and Omicron.
Yes, Delmicron, this, but it hasn't increased. See, that was about 2 weeks back.
Yeah.
And there's been no, it hasn't spread. As you notice that Omicron, when it came, 26 by the 1st of December, there were about 30 odd countries which were already having the infection. So every division of the virus will lead to mutation. Now, is that mutation significant? Is it giving significant advantage? That is what we have to worry. So the sooner we decrease the viral load, the more we will decrease the chance of a variant coming and then harming us. I think it has done a lot of damage, not only to the health, but also to the economy of the countries.
Is Bernard, are you there? Emily?
Hi, yes, we're here.
Yeah, I also have one or two questions. So how do you think HPV infection will impact COVID-19? I mean immunologically.
Yeah, so that's a good question. We honestly don't know without doing further laboratory experiments, I think. It'd be more so in more research-based, university setting. I would imagine would be the best bet on that. At the health department here, we don't have that sort of laboratory capacity. So hopefully, maybe some other agency or university would look into that a little bit further, I would think.
And HPV infection in the United States has become much more unusual given the uptake of the HPV vaccines, at least those specific 9 strains that are covered. So it would be a less common infection currently, probably than COVID.
Okay. Then I think your presentation, you raised some little fear. I don't know whether I'm calling it a fear of the potential of cross-reactivity between HPV vaccine and SARS-CoV-2. Where are the fears? Why do you have that fear?
I think based on some of the literature that we read in the more of the lab setting, and some of the papers are listed in the in the reference section. It was really just more of a hypothesis when the pandemic first started, just trying to think about just different ways in regards to maybe how other vaccines that we currently already have, because we didn't have the vaccine then for COVID. There's good representation of other vaccines creating cross reaction towards other pathogens. So it was more just a hypothesis, and we had access to a really good data set in regards to the immunization registries here in New York State. So it was a little bit easier for us to kind of run that sort of analysis. So
Okay. I think maybe we'll talk on that later and see how best we can work together and find a solution.
sure.
Thank
no
you.
problem.
Yeah. So, Prof. Pranab, do you have any question?
No, that's okay.
Okay, Tanima, take over.
Rather we should speak on in the next time about the treatment purpose. Professor Raton, I think that you have gone through the latest ICMR evaluation treatment protocol, but the basic problem with the COVID-19 is the thromboembolism and the injury to the vessel, particularly endothelial cells, and leading to much more clotting phenomenon and clot development of the clots. ICMR in the last protocol, in the Delta part, they included the anticoagulation like heparin, low molecular weight heparin or enoxan. But this time, with Omicron, because we are not very sure that every patient we are getting admitted with the severe pneumonia or the moderate pneumonia is by Omicron. It's maybe Delta, but the ICMR and even the government of West Bengal Health Department and also the central government has withdrawn many drugs, including these anticoagulant. I was talking just today with my director at the School of Tropical Medicine. Why did they do that? Actually, have you any idea about that? Why the anticoagulant has been off by the ICMR group?
It was the same question was asked from the DG ICMR, and he said that discussions are going on. But I've always felt that guidelines are guidelines. They are not. Ultimately, they've looked at the literature, they looked at pros and cons, and then they've written what they want to write. But I think it is within the power of each individual doctor who has to decide what he needs to give to the patient, to his patient. So if it is that guidance should be taken as only guidance, it cannot be a prescription for every patient that you have. So I think some parts individual clinician will have to exercise his own judgment and do what he feels is right. As you know, in the past, we know that D-dimer is increased, and if D-dimer is increased, you know what has to be done. So that would be done. But Omicron has led to very few admissions. I think they said 90% of beds are vacant, and they've led to some deaths. Yes, as I said, it doesn't make a person immortal, but the deaths have been very few and with very severe comorbidities. So people have died with Omicron than rather because of Omicron.
Because of comorbidities, you want to tell, not by the Omicron itself.
That's how it seems to be.
Emily, do you have any data on like the impact of COVID-19 on cancer cases in your facility?
No, we don't have any data on that. Have you seen any data on, I mean, we've certainly seen individuals who have been ill with many other different things, including cancer, and many individuals who are undergoing chemotherapy and who have been more susceptible to more severe cases of COVID-19 as a result. But in terms of in the other direction, COVID-19 affecting their cancer, I don't think we've seen anything on that.
Okay. I've also not come across any data. That's why I'm asking.
Okay.
Yeah. Oh, Professor Pranab, have you come across any data?
Regarding what? Regarding the
COVID-19 and cancer cases.
COVID-19 in, I cannot follow you.
I mean COVID-19 and cancer cases.
Cancer patient in COVID-19.
Yeah, something like that, yeah.
Yeah, like that. Now, actually, in our Calcutta School of Tropical Medicine, we had the patient of hematological cancers like lymphomas and leukemias, like that, mostly.
Okay.
Because it was a premier institute of hematology all over India. So many of those patients who were in the outdoor-based treatment, they could not come during the period of 2019 and 2021, 2020 to 2021, up to March. Because I was in charge of seeing the bone marrows and the blood, and I found that the number of patients what we used to see in our department previous to the 2019 reduced drastically, as per the patient could not come to the lockdown due to the lockdown, and obviously they could not also get the medicines supplied from that, or the chemotherapy or the radiotherapy, whatever was the treatment protocol for them. As a result of which, sudden I found particularly those patients who had the CML, many of patients came with the blast crisis and ultimately have COVID positivity, COVID-19 positivity. I remember a young adult who had got the ALL. He suddenly was admitted with a severe blast crisis. And I did the bone marrow and I found that the whole bone marrow, it started up with the lymphoblast. And he was COVID positive, and ultimately he succumbed by 2 or 3 days. That was the situation. Not only for that, the hemophilia patient, this hemophilia patient also couldn't come and could not get their anti-hemophilic therapies, prophylactic therapies. These were the problems. And so this patient should have much more better care in the home, but nobody could get this type of care during the period of the COVID-19. So long I was, after retirement in 2021, actually I have got little, I never went to in my department and I couldn't find, I didn't know the data, actually how much they are getting admitted. Because most of the bed in the medical colleges and even in the Calcutta School of Tropical Medicine has been converted into the COVID bed. And so the problem is with the admission, problem is with getting the chemotherapies, problem is with the getting their that is outdoor checkup, and everything. The problem was there. So long I was in Calcutta School of Tropical Medicine.
Okay.
After retirement, I have got no contact. I
Okay.
didn't come out for 1 month at least.
Okay, Professor Ratan. Since now we all agree that coronaviruses are here to stay, do you think it will be feasible for us to start thinking of developing edible vaccines, like a vaccine that will be put in, let's say, chocolate, like pizza?
Banana, actually, they had thought of banana. I think, the enteric pathogens,
Yeah.
there have been some attempts, but some, because it has to be on a vegetable which is not cooked. So it has to be eaten raw. That is one of so banana was one of the target vector. But I don't think it has moved too much, except for getting some grants here and there. And that is one of the. But maybe now that the messenger RNA technology has worked, I think, and more people will attempt into that. There is for whether it is traveler's diarrhea or whether Campylobacter, maybe they would move towards that, or Norwalk or rotavirus.
Yeah. Well, Emily, do you have any comment, Emily?
May I just have an opinion about that? Genus kinase inhibitors, they have got a very good promising result, probably also into the viral, this coronavirus, because that isn't how the cell are being killed by the virus. What is your opinion about the genus kinase inhibitors? JAK kinase too.
Yeah,
Janet
that has
kinase,
worked
okay.
in treatment. Yeah, IL-6 inhibitors and JAK inhibitors have been included in the treatment protocol. So
that is a very good drug, I think, for the COVID virus also, but very costly.
Mostly for disease. See,
mostly for
ultimately, from public health point of view, it is for transmission. Why it has spread is that the transmission started before you made the diagnosis. So the person has already spread the infection to many persons before he is isolated. So, so that all people have been trying to isolate or quarantine persons have been futile.
So in the case of prophylaxis and preventing transmission, what about your opinion regarding HCQ, hydroxychloroquine?
Well, the clinical trials have not even I always meet people who say ivermectin is good, and he said that the good point is ivermectin, even if it has not taken any action, and it is in vitro active again, it has in vitro activity against SARS-CoV-2, but now at least it should have cured all your parasites. So one point is, if you've taken ivermectin, it has a side effect that now the parasites are cleared, if not coronavirus. But
so, so what of a possibility of, let's say, cocktails of drugs, like the way we have in HIV?
See, that is only when you have to give long-term treatment. But as with molnupiravir, they have already shown that 4 days treatment will kill all the viruses and sterilize the nose and throat as far as SARS-CoV-2 is concerned. And it's just that it's toxic. So they'll have to get an analog which has more affinity for the viral RNA than for human genome. And then if it doesn't interfere, but as you know, we've taken people have been taking HIV drugs which have nucleotides in it, analogs, and with acceptable side effects. So that should be all right, I think.
Okay, Emily, do you have any? Emily, Brandon, do you have any any input?
We don't have any input in regards to the treatment cocktail, but based on Dr. Ratton's presentation there, there is some good antiviral drugs out there for reducing severity of illness. So it's very encouraging, and hopefully we'll see it get ramped up a little bit more in regards to access to that.
Okay. I think Professor Andrew, is not joining us because I don't know, she's not on. So since we've exhausted everything, Tanima, you can take over. Oh, Dr. John, do you have anything? Victor, Dr. Mala.
Well, nothing to add more than for this group to look at the challenges and come up with a position paper that can be shared with our government, in order to really interrupt the virus and be able to contain it effectively. That's my submission.
I didn't hear you properly. You say paper on what?
I said, if this group can come up with a paper on how to improve or how to contain these mutants effectively, disease, all these variants of concerns that are actually causing community transmission. So if you can just come up with suggestion or recommendation to governments that can be used and shared among us.
Okay, so I think from the suggestion of John, maybe I will invite some like Emily, Brendan, Professor Ratan, and Professor Pranab, and you, Dr. John and Tanima, so that we come out with a protocol or working paper which can be disseminated around the various government institutions. So maybe within next week, I'll send out emails with the proposal. Then we see how we can work on that. Is that okay?
Thank you. With your permission, I am leaving. I have got some other.
Yeah, I think we've adjusted the time.
My
So
wife is
Tanima,
calling
if
me.
you can
My
come in,
wife
then
is
we
calling me.
Yeah, absolutely. It was an amazing session, and I would like to heartily thanks all the dignified and eminent speakers. It was really wonderful and knowledgeable sessions, and we are heading forward for a few more sessions like this. Thank you all. Thank you so much for your
thank
time.
you very much. Thank you for this meeting. Bye.
Thank you very much.
Thank
Yeah,
you.
bye.
Thank you.
Bye.
Thank you.